Hi everyone, my name is Yawen. I'm a surgical resident at the HPB Center Clinic Favoriten in Vienna, Austria. As part of the ESDO LearningBytes, I've prepared a presentation of the topic cholangiocarcinoma with a special focus on the multidisciplinary approach. So before going into details how to diagnose or treat cholangiocarcinoma, or simply in short CCA, we first have to take a closer look at the different subtypes of CCA, because depending on where the cancer arises, we can differentiate between the intrahepatic CCA, which grows within the liver, or PCCA. The P stands for perihilar, which means that the left and right hepatic ducts and common hepatic duct are involved. And then we have the distal CCA, where the cancer affects the common bile duct. Together, the PCCA and DCCA are sometimes known under the term extrahepatic CCA. Interestingly, what we've seen in the last 2 decades is the rising incidence of the intrahepatic CCA, although the exact underlying cause for this development is yet to be determined. So in order to better understand the treatment algorithm of CCA, it's crucial to know its anatomy, especially when it comes to the perihilar subtype. In PCCA, one has to be familiar with the so-called Bismuth-Corlette classification, which basically gives us an overview of the location of the cancer. So for instance, a type 1 PCCA means that the tumor is below the hepatic confluence. Type 2 means that the tumor has already reached the hepatic confluence, whereas in type 3A, the tumor is not only to be found in the common hepatic duct, but has also infiltrated the right hepatic duct, and type 3B, the common hepatic and left hepatic duct. And finally, in type 4, the tumor is either multicentric or involves the confluence and both the right and left hepatic duct. So now, what does the diagnosis of CCA entail? Generally speaking, CCA arises from the epithelial cells of the bile ducts. It's still a rare cancer, but it's highly lethal because most patients with CCA are locally advanced at the time of diagnosis. Typical symptoms are, for instance, jaundice, abdominal pain, weight loss, fever, malaise, fatigue. The laboratory tests may reveal elevated cholestatic parameters such as bilirubin, GGT, ALP, or the liver enzymes ALT, AST, and the tumor marker CA-C99 may also be elevated. As for the radiographic findings, in the ultrasound you might find biliary duct dilatation or intrahepatic tumor mass, depending on with what kind of tumor subtype we are dealing with. And then, of course, we have to perform a staging CT, which gives us a better overview of the whole issue, the exact location of the tumor, whether there are also distant metastases, lymph nodes involved. And then we might also want a MRCP or MRI of the liver to see whether there are satellite lesions. And then naturally, if the patient has some kind of a biliary obstruction with high bilirubin level, and ERCP is an important diagnostic and therapeutic procedure where we can either perform a biliary stent implantation, and during this intervention we might also get a brush cytology or a fine needle aspiration. However, these diagnostic tests often come back negative, and we have to be aware of the high risk for ascending cholangitis, and the patient might also develop a post-ERCP pancreatitis. Next, if the patient is not upfront resectable, judging from the imaging, and we will talk about resectability a bit later, you might want to ask radiology to perform a CT or ultrasound guided biopsy for the patient in order to get a histology. In perihilar CCA, we often book a spyglass cholangioscopy for the patient, which allows direct visualization of the biliary duct system and subsequent diagnostic maneuvers like targeted biopsies of the pathological lesions. And finally, the patient's case, of course, has to be discussed within the multidisciplinary tumor board. So let's say we have completed all of the diagnostic tests and judging from the radiographic findings, the patient's tumor appears to be resectable, what are the discussion points that we as the surgical department have to talk through with the other specialties such as oncology, radiology, gastroenterology, etc. Is a preoperative biliary drainage necessary? If the tumor is upfront resectable, then definitely avoid percutaneous biopsy. Does the patient have some underlying liver injuries such as fatty liver disease or liver cirrhosis? So does he have a sufficient future liver remnant? Or should we optimize his future liver remnant first with the portal vein embolization combined with a hepatic vein occlusion? Should the patient undergo neoadjuvant systemic therapy? Is the radical surgery possible? So once all of these issues have been sorted out and the patient moves forward for the surgery, he will, of course, need adjuvant therapy for his tumor afterwards. What happens if the patient's tumor is not resectable and there are already distant metastases present at the time of diagnosis? Then, like we said earlier, we need a positive tumor histology for the oncologist to start him on a systemic therapy, of course, according to his performance status, and if the patient is a suitable candidate for a clinical trial, he should definitely be offered the chance to participate. So here we have a flow chart of the management and treatment options of CCA patients from a recent review in 2020. And once again, as mentioned earlier, the first important question is whether the tumor is resectable or not. And as you can see here, there is a huge difference in prognosis whether the patient's tumor is resectable or not. So let's say the patient has undergone the surgery and he will need adjuvant chemotherapy, which consists of 6 months of capecitabine, whereas in case the patient's tumor is not resectable, then the first-line systemic chemotherapy consists of the combination of gemcitabine and cisplatin, and the second-line chemotherapy is still FOLFOX. Now let's focus on the term future liver remnant, FLR in short. So basically the goal here is that the patient has a sufficient FLR so he does not develop a so-called post-hepatectomy liver failure. In patients with a normal liver function, we say that a FLR above 25% is enough, whereas in patients with pre-existing liver injuries such as steatosis or cirrhosis, the FLR should be above 30 to 40%. Moving forward to the surgical approach. So I guess one of the most important messages from this presentation is that the surgical resection is the only potentially curative treatment for patients with CCA. However, only 25% of CCA patients are resectable at the time of first diagnosis. The best case scenario is an R0 resection, where the margins of the tumor specimen are clear of tumor cells, and that the patient has an adequate liver remnant size. In general, we can differentiate between 3 categories, namely clearly resectable, clearly unresectable, and borderline resectable. And as mentioned earlier, this issue has to be discussed within the multidisciplinary tumor board. But there are, of course, exclusion criteria for resection, such as distant metastases, positive lymph nodes, celiac and intra-aortal cable, vascular encasement of the portal vein or common hepatic artery above 180 degrees, insufficient FLR for potential radical resection despite intervention to increase FLR such as portal vein embolization and hepatic vein occlusion. And finally, the localization of the tumor is essential for the extent of the surgical resection. So in case of an intrahepatic CCA, the extent of the liver resection is of course dependent upon size and location of the tumor. The patient will also need a lymphadenectomy and a cholecystectomy, whereas in the perihilar subtype, the patient most probably will get an extended hemihepatectomy, including the resection of the segment 1 and unblock resection of the extrahepatic biliary ducts, along with a cholecystectomy and lymphadenectomy. And finally, he will also receive a hepaticoduodenectomy. In the distal subtype, the standard procedure is still the Pylorus-preserving pancreaticoduodenectomy. Now just a few words on the anatomy of the liver. As most of you are familiar with the segments of the liver, we have in the left lateral section segment 2 and 3, and then the left medial section we have segment 4, which can be further divided into a segment 4A and 4B. And then segment 1, which is somewhat of a separate structure, and it receives blood flow from both the right and left side. Then the right anterior section with segment 8 and 5, and finally the right posterior section consisting of segment 7 and 6. And as you can see from this picture, we have 3 hepatic veins, namely right, middle, and left hepatic vein, all 3 draining into the inferior vena cava. And then, of course, in the porta hepatis, we have 3 important structures, namely the common bile duct, the portal vein, and the hepatic artery. So this slide should give you an overview on the different kinds of liver resections. So for instance, a right hemihepatectomy would mean the removal of segment 5 to 8 plus minus segment 1, whereas let's say a left lateral sectionectomy would mean the removal of the segment 2 and 3, or a right trisectionectomy, or also called extended right hemihepatectomy, would entail the removal of the segments 4, 5, 6, 7, 8 plus minus segment 1. So in case of a distal CCA, the standard procedure would be a Pylorus-preserving pancreaticoduodenectomy. And here on this graph, we have a comparison between the preoperative and postoperative situation. So as you can see, in a PPPD, we have 3 anastomosis, namely number 1, the anastomosis between the duodenum and jejunum, the so-called duodenectomy. And then we have the end-to-side pancreaticoduodenectomy, and finally the hepaticoduodenectomy. Now let's talk about the systemic therapy in CCA. As for the neoadjuvant / conversion / induction chemotherapy, there is still no consensus as of yet. It remains an individual decision in borderline resectable cases. So the standard chemotherapy here would be a combination of gemcitabine with cisplatin plus minus nab-paclitaxel. As for the adjuvant setting, the standard therapy consists of a 6-month treatment with capecitabine. And in case the patient has a locally advanced unresectable disease, he might either be offered the combination therapy with gemcitabine with cisplatin or gemcitabine and oxaliplatin. And if he has a poor performance status, he might receive a monotherapy with gemcitabine, capecitabine, or 5-FU. The standard second-line therapy still remains FOLFOX. So in the past decade, increasing efforts have been made to understand the complexity of CCA based on the molecular profiling of these tumors. And as a result, novel targeted therapies have been developed, which are now also administered in clinical settings. So for instance, pemigatinib, which is a FGFR1, 2, and 3 inhibitor, often found in iCCA, has been approved in March 2021 in Europe for the treatment of previously treated unresectable, locally advanced or metastatic cholangiocarcinoma with FGFR2 fusion or other rearrangement, and is therefore the first targeted treatment for CCA. And then we also have the IDH1 inhibitor, the so-called ivosidenib, which has also been approved by the FDA last year for the use in adult patients with previously treated local advanced and metastatic cholangiocarcinoma harboring an IDH1 mutation. So the IDH1, IDH2 mutations are more common in intrahepatic CCA in about 20%, as well as the FGFR2 fusions or rearrangements, also more common in intrahepatic CCA in about 15%. In contrast, the KRAS mutations are more frequently observed in the perihilar subtype, whereas the HER2 overexpression is more common in extrahepatic CCA in about 10 to 27%. Then we also have the BRAF V600E mutation, which can be found in approximately 5% of intrahepatic CCA cases. And then finally, the MSI, the microsatellite instability, only in about 1% of all CCA subtypes. And finally, a few words on the targeted therapies and future prospects in CCA. As mentioned earlier, the FGFR inhibitor pemigatinib has already been approved based on the results of the FI-202 trial. Other FGFR inhibitors include infigratinib and erdafitinib. And then we have the IDH1 inhibitor ivosidenib, which has also been approved based on the results of the Clarity trial. And then the BRAF inhibitor dabrafenib in combination with the MEK inhibitor trametinib, which are undergoing testing within the RAW basket trial. And then finally, with regards to the checkpoint inhibitors, we have the pembrolizumab currently undergoing testing within the Keynote 150A trial, either as monotherapy or in combination with gemcitabine and cisplatin within the Keynote 966 trial. So in summary, the take-home messages from this presentation. Each anatomic subtype has distinct genetic aberrations, clinical presentations, and therapeutic approaches. Surgery is the only potentially curative treatment option for patients with CCA. However, only approximately 25% of CCA patients are resectable at the time of diagnosis. On the basis of the BILCAP study, capecitabine remains the gold standard in the adjuvant setting. In patients with advanced stage inoperable CCA, the first-line systemic therapy consists of cisplatin and gemcitabine. FOLFOX has been established as a standard second-line therapy. Recent advances identifying genetic alterations in CCA highlight the emergent role of precision medicine for this dismal disease. Thank you for your attention.